It's now my pleasure to introduce Caleb Alexander. I had the good fortune to be on the faculty with Caleb for a number of years here at the University of Chicago. He is now the Assistant Professor of Epidemiology in the Bloomberg School of Public Health with a joint appointment in the School of Medicine at Johns Hopkins University. He's a practicing general internist, health services researcher, and pharmacoepidemiologist. His research examines three interrelated areas of medication use. First, the patient-physician communication and decision-making regarding prescription drugs. Second, population-based patterns and determinants of pharmaceutical use. And third, the impact of changes in pharmaceutical policy on pharmaceutical expenditures and utilization. His talk today is entitled, Physician, Heal Thyself.
Thank you. Well, it's great to be here, and as you've heard, I've migrated east. Earlier this year, my family and I moved to Baltimore to be closer to our extended family. It's been very exciting to be at Johns Hopkins, but it's wonderful to come back and see so many friends and colleagues. When Mark asked me for a title for this talk, I proposed Physician, Heal Thyself, or Heal Thyself. And someone asked me today if I was going to speak about VEACH, and I hope you're not too disappointed, but this doesn't have a lot to do with VEACH. And in thinking about the title, I actually thought maybe a more appropriate one was Prescriber, Heal Thyself. More than 15% of prescription drugs are actually prescribed by non-physicians, so nurse practitioners, physician's assistants, dentists, and other licensed practitioners. So my comments are really relevant to the broader community of prescribers. And what I want to talk about is prescription drug poisoning. Really the fastest growing drug problem in the United States today. And I don't know how many of you walked in here already knowing this, but I hope that all of you leave understanding the scope of the epidemic. So I'm going to provide a little bit of data and then also talk a little bit about what I think this has to do with the art of medicine. Probably the most visible aspect of this epidemic are the deaths, and ranging from Anna Nicole Smith or Heath Ledger or other celebrities to individuals within their own communities, and their deaths generally at young ages, of course, shatter the families and the communities of which those individuals are a part. During the past few years, we've reached two very dubious milestones. The first is presented here, that prescription painkillers now kill more Americans than heroin and cocaine combined. And this has actually been a problem a long time in the making. So even though it's only been within the past 12 to 24 months, I would argue that policymakers and the general public and the clinical community has really started to pay more attention to this. I'll show data that demonstrates that this has been a problem a long time in the making. One sidebar, of course, is that I'm only discussing prescription opioids because this is really the elephant in the room when you talk about medication abuse. But drugs such as sedatives and anxiolytics and hypnotics, stimulants, there are many other drug classes that are also widely abused and used for non-medical purposes. So this is the first milestone, and the second is even a little more stunning, I think, at least given the amount of focus that we give to motor vehicle accidents, which is that more people now die of drug poisonings than of motor vehicle accidents in the United States. So to say that again, last year more people died from drug poisonings than motor vehicle accidents. Here on the y-axis you have rate per 100,000, you see motor vehicle traffic in the black, and poisonings and drug poisonings in blue and red respectively from 1980 to 2008. But the deaths are just really the tip of the iceberg. So for every individual who dies, there are many, many more that are impacted, whether going to emergency departments to be seen, whether evaluated in drug treatment facilities, whether living day to day with ongoing abuse or non-medical use, or whether reporting a history of non-medical use within the previous 12 months. So although the deaths really attract most of the attention, the epidemic itself is much more broad in its impact in the population that it touches. So where on earth are all the medicines coming from, you might wonder? One national survey conducted by the National Center for Health Statistics suggests that many adolescents find it easier to get prescription drugs than they do to buy beer. And there are actually several different sources of information about where drugs are diverted and where the drugs come from that are used for non-medical purposes. And in some sense, knowing the answer to this is kind of the holy grail. It's tempting to think that there's a single answer, but of course there's diversion at every step in the drug pipeline, from manufacturers and distributors and wholesalers to pharmacies, warehouses, hospitals, clinics, physicians' offices. There's even an anecdote that I heard last month about a fellow that was going house to house looking for, he was posing as a home purchaser and having real estate agents show him around the neighborhood so that he could get into the medicine cabinets of the houses that he was looking at and empty them out. So there's no single source for the drugs. This is a graphic from the CDC, from Grant Baldwin and colleagues there, and it's focused really on leverage points where strategies or points of intervention may be used for preventing misuse, abuse, and overdose. But I think it also demonstrates the point that I just made. These are touch points for a reason, and that is because they're all sources where non-medical use can occur or be facilitated. I'm going to focus on clinicians. After all, this session is about the art of medicine, and what I want to focus on is clinicians, doctors, nurse practitioners, physician's assistants, ourselves, our colleagues, the people that we see for care. Now, it may be tempting to think that this is just a problem of rogue prescribers, but I'll provide data suggesting that that's not the case. Sure, there's the case of the physician in Louisiana that was seeing 200 to 300 patients a day, accepting cash only, doing 3-minute physical exams, and dispensing more opioids than the neighboring county combined, than all the clinicians in the neighboring county combined, but those are, I think, the exception rather than the norm. So this is the first bit of suggestive evidence that I'd like to present, and on the y-axis we have rate ranging from 0 to 8, and these are rates per 10,000 or 100,000 people, and this depicts rates of sales, that is opioid prescription sales, deaths, and treatment admissions to treatment facilities. And you don't need a doctorate in biostatistics to see that there's some correlation here at the very least. That is, each of these marches step in step over the period from 1999 to 2010. Now, you also don't need a doctorate in biostatistics to know that correlation doesn't equal causation, and there's a number of different stories that we could tell that might explain what's going on here. But I'm not sure it matters so much for the purposes of my talk and one of the claims that I want to make, which is that under current regulatory and clinical conditions, we shouldn't expect reductions in the morbidity and mortality and community strife that caused by non-medical use of opioids until the opioid sales decrease, that is, until we see decreased utilization of these in clinical practice. There are some other sources of information about this. So these data are from the National Survey on Drug Use and Health, conducted by the National Center for Health Statistics. What are the sources of prescription drugs for non-medical use? Well, I've talked a little about drug thefts. Cardinal Health was shut down for unscrupulous distribution practices, warehousing in Florida, doctor shopping, internet pharmacies. But what about physician visits? And what about friends or family? So this on the right is a graphic of people who abuse prescription painkillers and where they report getting their drugs. Look at the bottom right from 3 to 6 o'clock or so. Almost 20% report that they got them from a physician, from a single physician, and 55% report that they got them from friends or family for free. Well, where do you think the friends or family have gotten them from? So other evidence suggests that the majority of these individuals get them from a clinician, from a licensed prescriber. So these aren't just medicines coming from a holdup in Brooklyn where a guy goes in and shoots 2 people and takes a bag of OxyContin. So I think it's pretty clear, and this is of course a very top of the trees view, that we've got a big problem here. And there's a lot of aspects to the problem that I can't touch upon for the sake of time, although I'd be happy to in the Q&A. There are a gazillion stakeholders involved. This is like the blind man and the elephant. They all have their own perspective. They all have their own economic incentives and interests. They have their interests to preserve. They have their respective stakeholders or audiences. They're complex determinants of use and abuse. we've made unclear progress in the identification and treatment of pain. And this is, in fact, an area where we have active investigations at Hopkins, where we're analyzing nationally representative data to see how well we've done in improving in the diagnosis and treatment of chronic pain. There are unknown effects of interventions to reduce non-medical use. I have a slide deck about PDMPs, prescription drug monitoring programs we can discuss. And even the epidemiology of opioid utilization, prescribing, and dispensing is fairly ill-defined. But I think even with the data that I presented here, it raises several questions. The first is the degree to which there is a true tension between patient advocacy on the one hand and a broader societal good on the other. And I would argue that there is. I would argue that we have sufficient evidence to think that there is. And the question is really, how should this be resolved? And as I was thinking about this a little bit, I wondered whether there are some other settings, such as some of the literature and bioethics discourse regarding bedside rationing or surrogate decision-making, that may provide some guidance, because these are very different settings, but there are some analogies to the current case. What's the appropriate role of the professions, I think, is a reasonable question, and many professional societies have been fairly quiet regarding this epidemic. And finally, what about balancing beneficence and non-maleficence, even in the setting where there's a good clinical indication, even apart from worrying about the externalities involved in any given patient in front of you? That is, even apart from worrying whether the medicines that I prescribe for my patient get to another patient or someone who's going to abuse them, most RCTs of opioids have been for short-term use, have been placebo-controlled, and have used screening methods to screen out people that are prone to abuse or misuse. And this is a far cry from the real-world settings where opioids are used these days. So next week we have, this is sort of fortuitous timing, so next week we have an editorial in JAMA that expands upon these comments a bit. And I certainly appreciate the chance to share some of this with you, and also look forward to your thoughts and comments. Thank you.